At this point, if we have either Ken or Jason at UC Irvine, we're happy to go to you live.
Hi, Tom. Can you hear us?
I think that was Ken.
Yep. I think you're at UCLA. Let's come back to UCI. Orange County, please. OC, please. There you go.
There we go. Perfect. Okay, now we see you.
Okay. Hi, Tom.
Again.
How was lunch?
Oh my gosh, it was so good. There's lobster rolls. I would suggest all of your staff come down here to the Ritz. You aren't that far from here. Sorry, Tom. Can I invite all the whole UC Irvine team? Yep, Tom says whole UC Irvine team, come on down.
We'll come right after the case. We'll be there. So let me introduce to you Mark Moniches, who's our advanced fellow, finishing his last few months of his advanced training. He's going to present the case today, which hopefully should be quite interesting.
Good afternoon, everybody. Thanks for joining us. So we're going to do an endo-hepatology demonstration. This is a 50-year-old female with a history of morbid obesity, BMI 48, sleep apnea, type 2 diabetes, and suspected cirrhosis secondary to non-alcoholic fatty liver disease. She had a recent flare of her liver enzymes and her immunoglobulin levels while she was hospitalized for an episode of urosepsis. Liver enzymes have downtrended but not fully normalized, but her immunoglobulins remain very elevated despite 5 months of resolution. There's a concern for possible underlying autoimmune liver disease given her recent presentation and lack of normalization. And as such, she's been referred to us for evaluation with EGD for assessment of varices and EUS for assessment of fibrosis, liver biopsy, and portal pressure measurements. So this lovely Excel graph here shows her bilirubin levels. As you can see, prior to presentation to hospital, fairly normal levels of her immunoglobulins and liver enzymes, the purple line being her immunoglobulins. And what you can see—
that's the bilirubin.
Oh, her bilirubin, sorry. What you can see is then there was an acute spike during her presentation, fairly rapid, and then a slower downtrend to still slightly elevated level around 2 currently. Her platelet count shown here in purple also shows there's been a persistent downtrend over time, concerning for developing portal hypertension. Her current labs show slightly elevated AST of 60, ALT of 36, alkaline phosphatase of 216, bilirubin slightly elevated 2.1. She is thrombocytopenic and very mild coagulopathy developing with an INR of 1.18. She's had a prior workup, very extensive, ruling out viral hepatitis, Wilson's disease, alpha-1 antitrypsin. Her prior serologies for classic markers of autoimmune disease and PBC were all negative. However, as you can see, her total immunoglobulin quite significantly elevated at 2,500. IgG4 is also slightly above. Her A1C is seen 10.2, indicating poorly controlled diabetes. A FibroScan in January of this year showed a mean value of 23.5 kilopascals, consistent with stage 4 hepatic fibrosis. But given her obesity, these can sometimes be difficult to interpret. CT abdomen earlier in this year showed a very enlarged liver measuring 19 centimeters, cirrhotic liver morphology with large perisplenic and perigastric varices, and a large gastric varix was seen as shown in the image, showing a large spleen and liver. So the questions today are, does the patient have portal hypertension from cirrhosis, or is there another cause such as a portal vein or splenic vein thrombosis, which we haven't appreciated? And is there portal hypertensive gastropathy or true evidence of varices on endoscopy? If there is cirrhosis, how severe is it? Is portal hypertension present? And will this dictate management, such as starting medication, referral for consideration for TIPS if quite severe to prevent bleeding from her varices? And will this impact her overall prognosis? And then we do want to clarify the etiology of her liver disease. Is this NASH? Is there an autoimmune component? And whether this change treatment?
And also, if the patient with her morbid obesity wants to lose weight, she would need a gastric bypass or a sleeve. And is it safe, feasible to do that? How bad is her portal hypertension by way of surgical risk?
So plan today is for EGD, which we've done off screen, and we'll show you some representative photos, EUS shear wave to assess fibrosis of the liver and spleen, and then we'll finish with a liver biopsy and portal pressure measurements.
So Tom, we took some EGD pictures while you were eating lobster. We did the EGD. Go ahead, Mark.
Yeah, so as you can see here, this is bottom of esophagus at the G junction. We didn't see any esophageal varices, normal evaluation. Go to the next photo. However, in the stomach on retroflexion, you can see a large fundic gland varix. This would probably be an isolated gastric varix type 1, as it did not communicate with the G junction or esophagus. Very large, and on EUS, as we'll show you, very dilated. Looking at her stomach, there was no obvious portal to hypertensive gastropathy. It did have a slightly denuded appearance. We felt there could be signs of early gastric intestinal metaplasia, but no portal hypertensive gastropathy.
Okay, thanks, Mark. Great job. So, Tom, I don't know if you have any questions or if there are any hepatologists in the room. Be happy to hear like what the thoughts are.
I'll ask the room if there's any thoughts, anything jumping out at you unusual about this case. Usual. I mean, Ken, it does strike me as you have a very isolated gastric varices. You know, I think there was the one big one, and I thought I saw some other small ones too with no esophageal, and I presume they've never been treated. So, you know, it kind of starts making me wonder about other etiologies for isolated gastric varices. So that's right. One thought. But no, we're curious to see what you see with the US. You'll see, show us some collaterals and show us some of the other things you're doing.
Okay, great. Thank you. So how's the image? Are you seeing the US liver okay?
Yeah, we can see it okay.
Okay, I'm going to make it a little brighter. Tell me if it's too bright. Is that okay?
No, you're fine.
Okay. So in terms of assessing the liver, the first thing we do on US imaging is to look at the liver contour. So what we're doing now is looking at the edge of the liver here, and it is slightly blunted. The normal liver should contour with the stomach wall and should not bullnose out like this. So this is suggestive of cirrhosis when you get this bullnose blunted liver edge. The other thing we look at is the liver surface. And if you can see here, let me freeze the image. You can see that the liver surface is not totally smooth. There is some undulation of the liver surface, and that's the other indication of possible cirrhosis. But then, then we have shear wave elastography as well. So let me show you shear wave elastography, which we talked about at the lecture.
And Ken, is the shear wave built into the scope that you're using?
Yes. This is the Arietta 850, I believe is the number, and it's part of it. All right, so I'm going to get to a relatively stable area. This is the left lobe. As we talked about in lecture, we can measure the shear wave in the left lobe and in the right lobe. So I just hit the shear wave button, and you get this nice little box that's 2 centimeters by 1 centimeter in size. And then once your image is stable, you just hit the update button, and it gives you the value. So let me give you a different. Hold on. I'm going to give you a new fresh map here. Okay. Okay. So for example, we here the shear wave shows that the E value is 23.03, and that's the stiffness. So we heard from the percutaneous transient elastography was 29, I think, or 27. So we're getting a similar value of 23. So there's the E value is in kilopascals. The VSN is a reliability measurement. Anything greater than 50 is considered quite reliable. It speaks to the evaluation within the box that has gotten data and signal back. So 75% of the box has been assayed. So that's a very good predict of reliability. And then there's the interquartile range and the speed. But the main thing that we look at is the VSN at 75%, and the elasticity value of 23.03. We did 10 passes off camera, and Eliza, what was the total on that? Okay, left lobe, the median left lobe after 10 passes like this was 20.1. So it's quite high. Our data shows that anything over 12.5 predicts highly F3, F4 fibrosis on Medivir score. Okay, so then we can also take a look at the spleen, but before I go there, let me show you the gastric varix. So I'm gonna come back here, and you're gonna see these are collateral vessels that are coming into view now, and I'm gonna turn on the E-flow, and you can see these perigastric vessels, and then I'm going to locate the ones we saw on the endoscopy. Those are the most dramatic.
Those are definitely prominent. Those are
Yep.
jumping
Very,
out
very,
at
very
us.
prominent.
Wow.
Yep. These are the most, these are the largest here, Tom.
Yep.
So huge gastric varices.
Can you just
And
measure one of those for us, and just so people can like appreciate how massive those are?
that's about 5 centimeters there.
Yeah, that's a big, that's like 5 by 2.5 or 5 by 2 centimeter varix. Those are big.
Yeah, those are huge. That's why I'm being very gentle with the echo endoscope. Okay, so we're gonna take a look. So these this is the true gastric varices. You can see it's only surrounded by some mucosa here. And now I'm going to take a look at the spleen. So this is the splenic vein. You can see the turbulent flow, and the splenic vein is enlarged. This is the pancreas. This is the body of the pancreas. It's a little fatty. There's the PD. So I'm going to follow the splenic vein towards the spleen now. And now we're imaging over the spleen. So the spleen is ginormous. Is that a good word? So if I were to measure from somewhere around here to somewhere around here, it's about 16 centimeters across, so very, very large spleen. And we can also measure the spleen shear wave, which, as I mentioned in the lecture, has some real advantages because neither fat nor inflammation is affecting the spleen. So the only thing in this case that would make the spleen stiff is portal hypertension. So it does take away some of the limitations that we see with transient elastography, and that's one of the advantages of MR elastography, because MR elastography can also measure spleen. So here we're going to give you shear wave. We're going to give you a new map. We're going to put the cursor right here. Okay, so the VSN is 98%, so very reliable. The stiffness value, the E value is 18.8. And what was the median that we got for spleen? 37.6. Okay, we got 27.6 after 10 passes. So very high. And again, we've shown anything in the 20s is elevated. So we've got an elevated spleen stiffness as well as elevated liver stiffness. So now the story is becoming more and more consistent that this is likely portal hypertension from the liver, from cirrhosis, as opposed to prehepatic portal hypertension or splenic vein thrombosis or portal vein thrombosis or idiopathic non-cirrhotic portal hypertension. Those are, less likely now that we've gotten shear wave of both the liver and the spleen.
Ken, we have a question at the mic.
Yeah.
Anas Kawai with the private practice GI. Is this shear wave measurement included in the EUS machine, or is that something that is developed by you? Like a certain protocol you use, or just interested in knowing more about that?
Yeah, so it's available. It's standard on the Arietta 850 EUS processor. You don't have to, it's not an additional hardware or software. It's built in. But a lot of people don't know it's there or know how to use it or appreciate how to use it. It's quite easy, but there are some nuances in terms of how to position the probe, because you want to get good acoustic coupling. You want to get nice coupling and good imaging. But one issue is if I crank too hard on my knob and I compress the liver or compress the spleen, I can artificially create some stiffness by pressing on the organ that I'm measuring. So that's the main issue, that we just need to understand that concept and not compress the organ that we're trying to assess.
Got it. So I know you did some measurements off camera. Are you doing, how many measurements are you doing for the right lobe, left lobe? And I'm guessing you're doing few for the spleen. So if you can walk us through.
Yeah. So I
protocol,
do 10 measurements, 10 passes.
and
So
that's
each,
10 for the whole liver, like 5 and 5?
nope,
Or
I
10
do 10 left lobe, 10 right lobe, 10 spleen.
Okay, and then you average it out, right?
Yeah, it gives you the median and the mean, and it also gives you the interquartile variability, and we like it to be less than 30%. So some of the values, if the VSN is too low, we can take that value out, or if the compression is too high, we can take the value out. So there's a bit of, after you do your 10 passes, you can eliminate some that are not good quality and then replace that with additional passes. But the sum total is you want to get 10 good numbers with a high VSN.
And high VSN is what's acceptable, 75 and above?
50 and above is considered acceptable.
50 and above. Thank you.
You're welcome.
And we're going to
Yeah.
switch over to UCLA for a sec, if that's okay. They've got something they want to show us, and we'll be right back to you.
Absolutely.
All right, we're back in UCLA. Stephen, how you doing? I think we can't hear you, though.
Can you guys hear me now?
We can.
Oh, great. All right, so welcome back. Hope you guys had a nice lunch. So we'll have our advanced fellow here present the case, and then we'll do the EUS.
So this is a 68-year-old gentleman with a history of chronic calcific alcoholic pancreatitis complicated by chronic abdominal pain, PD stones, with several ERCPs previously with stone removal and stent placement. Now here with recurrent abdominal pain. His chronic pancreatitis history, he had multiple PD stones found in May 2018. Then went ERCP with stent placement at that time. He also had a repeat ERCP with pancreatoscopy, EHL, stent replacement in June. In July, he had PD stone removal and stent removal. Unfortunately, in 2019, he developed recurrent PD stones, again required pancreatoscopy, EHL, stone removal, stent placement. At this time, he had a distal 1 centimeter PD stricture noted. And so in May 2019, his last ERCP, there was improvement in stricture noted after stent placement. He underwent balloon dilation, stone removal again, and final stent removal. His MRCP most recently on March 2022, when he presented with abdominal pain, showed recurrent PD stones. PD dilation and distal CVD narrowing with upstream dilation. Liver function tests have been normal. So the plan today is EUS ERCP with PD stone removal, possible pancreatoscopy EHL, and possible stent placement.
All right.
And is he currently
All right.
an outpatient or an inpatient?
He is an outpatient. Unfortunately, he has had, previously had some alcohol abuse. He actually did very well following his initial ERCPs a few years ago. Pain-free for several years. He was not drinking. And then he had some personal issues that came up more recently, particularly in the setting of COVID. There's some unfortunate family events that occurred, and that led him to start drinking again. And sure enough, several months after restarting alcohol, he developed recurrent pain, and he was admitted about a month ago or so with this pain and was found to have that MRCP findings of recurrent PD stones and that dilated PD, all changes of chronic calcific pancreatitis. So I'm going to demonstrate the EUS first today, and then we'll come back and do the ERCP. But I just wanted to show some of the EUS findings of chronic pancreatitis today. He's got a lot of the classic findings. So I'm here in I'll show you, this is the aorta, the celiac artery takeoff. So now I'm looking here at the neck body of the pancreas, and you can see this big dilated PD right there. I'm going to freeze this. This is his pancreatic duct, measuring about 8 millimeters in diameter. And if we follow this PD in his pancreas, you can see that there's a ton of calcification. Right? Typically, the pancreas on EUS looks like a salt and pepper appearance. This looks more like a starry sky or a Christmas tree with lights on it. You can see all these calcifications throughout this atrophic pancreas. So here I'm going across the body and tail of the pancreas. You can see all the calcifications. It's very hypoechoic or dark, lobular. It meets a lot of the Rosemont criteria for chronic pancreatitis, which are the EUS criteria.
I have a question for you, Dr. Kim. If you saw stuff like this and you ruled out malignancy and you think that it's just chronic pancreatitis, but the patient was doing fine, didn't have any symptoms, no malabsorption symptoms, no pain, would you go after the stones that are in the duct or the stricture or anything like that?
I think it's a good question. Typically for asymptomatic patients, I don't intervene at all. So if we have this finding incidentally on a CT scan or MRI, and patients are doing fine, I would leave them alone. Obviously, in this case, he's very symptomatic, and I know that he's actually done well following these ERCPs with removal of the stones and management of his pancreatic duct stricture. So I've now moved to the head of the pancreas and the bulb. You can see this is his bile duct here. It's quite dilated, likely from maybe an early distal CVD stricture from chronic pancreatitis. I'm measuring 9 millimeters here. The MRCP caught, I think, 14 or 15 millimeters. Fortunately, his liver tests have remained normal, so I don't plan on doing a biliary ERCP today because liver tests have remained okay for the most part. If they were to become elevated, obviously, I'd just consider putting in a stent and managing this distal CVD stricture. So one thing I want to rule out is a mass. I think you saw the MRCP images. It's almost like he's got a double duct sign. So I'm on the EUS now, I'm looking from B2, pulling back, looking at the uncinate pancreas. I'm going to be looking at the head ampulla in a second. Once again, you see this very chronic pancreatitis changes.
Tough with all the calcifications sometimes, right? All the artifacts and the shadowing.
Yeah. So you can see the CVD there. The PD is underneath. This is CVD here, PD down here, and there might be even a stone right here in the pancreatic duct where you see this bright calcification.
I think it's a good example where it is hard to ever completely say there's no mass in there because there's so much calcification and shadowing. You can, usually I'll put in my reports cannot completely exclude an underlying neoplasm because it's so calcified.
Agreed. I totally agree with you. It is really hard to image and rule out a malignancy.
No, Dr. Kim, we're going to switch over to Ken. Oh, we see some stones in the gallbladder there. Lots of little stones. Good.
Yep.
Um,
Yeah, I think that's great. So
we're
I
going
think
to
we can switch over to Ken, and we'll set up for the
to Ken,
ERCP.
and then Ken. Perfect. Thanks. So Ken, we're going to be switching back to you. I see. Yep, we've got you.
Hi, Tom.
Hey, Ken, we can see
so
you.
we're-
And perfect.
Yeah. I'm going to show you a little bit of the liver anatomy in terms of how we identify the various vessels. And then we're going to do the EUS portal pressure gradient measurement demonstration. So I'm looking right now at the left lobe of the liver. And you can see here, this is the diaphragm. This is the bottom of the left ventricle. So we're looking kind of up from the stomach. And so as I rotate towards my right, I'm going to look for the left hepatic vein. This is one of the branches of the left hepatic vein. This is the main left hepatic vein. So this left hepatic vein separates the liver segments 2 and 3. So if I pause here, this would be liver segment 2, and this would be liver segment 3. How do I know that's the left hepatic vein? Because I've been doing this for 10 years? No. So what we do is we follow the vein, and all the hepatic veins, need to get to the IVC. So if you follow this vein here, and I'm going to pull my scope back a little bit. That's the IVC. So this is the IVC. And so this is part of that left hepatic vein. And this going down is the middle hepatic vein. So we have middle hepatic vein. That separates segments 4, which is where my arrow is, and segment 8. And then this is the left hepatic vein, which separates, as we talked about, segments 2 and 3. So back to, this is the left hepatic vein, segments 2 and 3. And then the portal vein, the left portal vein, I just turned my scope a little bit to the right. And this is the umbilical portion of the left portal vein. You can tell by its thick hyperechoic wall. And then out here is a very important landmark. This is the ligamentum teres, which used to be the umbilical vein, and that leads right into the umbilical portion of the left portal vein. So today we're going to be targeting both of these vessels. We're going to target the left hepatic vein as well as the left portal vein. We're going to put the Insight device, which is a 25 gauge needle, into each of those vessels. And we're going to measure the intravascular pressure directly through the needle, which is attached to a pressure gauge. Any questions before I go to the procedure?
Ken, do you have any concerns about bleeding when you're putting needles into these vessels?
Yes and no. The safety measures is that this is, as Jason talked about, transgastric, transliver. So the needle is going, 25 gauge needle is going through the stomach and going into liver parenchyma before it punctures the vessel. When you remove the needle from the vessel, the liver parenchyma will tamponade your puncture hole. And so it makes the chance of bleeding out of the liver extremely low because of the size of the needle and the fact that the liver is tamponading. So we have not, we've done about 300 cases and we've not had a bleed from EOS PPG. Of course, we have a cutoff of platelet count. We don't like to do platelet count under 50,000. Her platelet count is 79,000, so I think we're okay. Now, obviously, I don't want to put my needle through those big, juicy gastric varices. So that's the main concern today. I don't want to do that. But short of that, I'm quite comfortable.
Right.
All right. So I'm going to position myself and find my target, which is that left hepatic vein. Let me see if I can. So this is the middle hepatic vein here, and it's a little bit far, right, for me to go from there to there. So I'm gonna come over here to there. That's a little bit better. So now I'm looking at this vessel here, which is part of the left hepatic vein. It's coming back into the IVC. We're getting a little bit of liver here. And so let me see if I can even back up a little bit more. That's even better, more clear. And before I do anything, I'm going to do a pulse wave Doppler just to confirm that the vessel I think I'm going into is the vessel I'm going into. So here's pulse wave. So you can see here, the pulse wave is not the portal vein, right? This is a four-phasic pulse wave that's characteristic of the hepatic veins and characteristic of the IVC. So this is clearly the right vessel. It's not the continuous venous hum that we're used to on the portal vein side. Okay, now let's see. I want to just make sure I got my target. So I'm trying to angle it so that I'm going to go through some liver and land in the vessel. So let me see if I can, and not hit the varix. So if I go a little bit further, that's a varix. See, that's a varix. I don't want to do that. So I'm going to move back, and I'm trying to find a spot that is. So that's devoid of varices in my needle path. So that makes me happy. And I'm going to back up just a little bit here. Okay, I think I like that. Okay, so now Amber is going to hand me the needle. So the needle goes down the inlet of the channel, just like any FNA. I'm going to lock
this is a standard 25 gauge needle with stylet, without stylet?
No stylet, and it's a 25 gauge needle, but it's gone through a lot of engineering and processing and approval for FDA for this indication. So it's not like your off the shelf 25 gauge. Okay, so what you'll see also once we get that situated is you'll see another picture in picture, and that picture in picture is the display. So Mark is going to put the camera a little bit more on top of the. Yep, perfect. Okay. So I don't know if it's broadcasting yet. We have a little separate camera pointing at the display. But
I don't see the picture in picture you're talking about yet.
Okay, it's
now
coming
it's
soon.
maybe.
Coming soon.
Perfect.
Are you getting it yet? No, not yet. Hold on. We're
And Ken, is there a special position the patient should be in, either supine or left lateral, or does it matter?
Great question. The patient is supine because that's how we can make sure that the pressure gauge, the manometer, has to be at what we call the phlebostatic point, which is mid-axillary. So it's at the level of her mid-axillary chest. So she's supine, and we've got it on a stable level table next to me on my left there. And so because the pressure is being read off the manometer, but the manometer needs to be 0 to the patient's right atrium.
Sure.
So,
and do you have, by being supine, are they in general anesthesia, intubated?
Yeah, so she's intubated under general anesthesia. This can be done under max sedation. It can be done under moderate sedation, although typically we don't like to do that because if the patient moves, especially during a liver biopsy, that could be a little bit poor form. So yeah, now because of the level of sedation, you can change the absolute pressure in the vessels by higher sedation or lower sedation. but the gradient is always consistent because whatever you change on the hepatic vein side, you'll also change on the portal vein side. So a lot of the HVPG, talks about minimal sedation, but we find that the level of sedation is fine, whatever suits the patient and their situation. But it's the gradient that we really are concerned about. Okay, so we're setting up.
Ken, we may need to go to UCLA soon. If you think it's going to take a little bit, we can switch, or if you think you've got a good window, we can.
It's I'm ready. It's just we're having a little bit of technical difficulty to give you the manometer view, but I think we can. Or I can just read out the numbers and you'll have to trust me.
We trust you.
Okay. All right. So, all right. So I'm going to go ahead and get ready here. Okay. Amber, if you can just hold me right there. All right. No, hold on. Hold on. Let go for a second. Okay. Right there. Right there. Okay. Okay. There's my needle. And I'm going to, once I get it in position, I'm going to do a quick jab. So I'm in position. And I did a quick jab. I went through and through, which is a perfectly reasonable technique. And so now I'm going to come back and back my needle tip right into the vessel. So I'm backing up, backing up, backing up, backing up. And I should be in. I may be off just a smidge. So, yep, I'm off. Okay, so I'm going to come back a little bit and retarget. Okay, how about here? Yeah, I'm going to retarget that. Okay. All right. I am in. The needle is in the vessel now. And Mark is going to go ahead and just flush it a little bit. Perfect. Thank you. All right. So now I'll go ahead and read the numbers.
60,
60,
38,
38,
30,
30,
25,
25,
22,
22,
20,
20,
18,
18,
17.
17,
It's holding at 17.
17. Okay. Hold
Give the
on.
manometer up too.
Uh-huh.
Still holding 17.
17.
Yeah.
Okay. So the first number will say 17. Next, flush
Okay.
again.
Flushing.
Okay, good.
85,
85,
60,
60,
45,
45,
34,
34,
27,
27,
22,
22,
20.
20.
Holding at 20.
Is it still
19,
19,
19.
19.
Still 19.
Okay, 19. Okay. Flush again.
Flushing.
Okay, good.
90,
90,
80,
80,
60,
60,
45,
45,
32,
32,
26,
26,
22,
22,
21,
21,
20,
20,
19.
19.
Holding at 19.
Okay. So what
18.
were the, 18. Okay. So what were the three numbers so far?
17, 19, 18.
17, 19, 18. Let's do one more.
Okay. Flushing.
Good. Nice. I see the micro bubbles.
70, 60, 50, 40, 30, 25, 22, 20, 19,
Uh-huh.
19,
18,
18,
18.
holding 18,
Okay, 18. What were the last three consecutive numbers?
19, 18, 18.
19, 18, 18. So those are pretty precise. So we'll keep those as the three numbers. And now, Tom, I'm just going to take the needle out of the vessel. I'm going to bring it back into the liver parenchyma, which is right here. And now I'm going to stay in that position. I'm going to turn on the E-flow so you can see the movement in the vessel, but not in the needle tract. So I'm just assessing and making sure there's no flow in the needle tract. And then I'm going to continue to back the needle out. I'm going to stop here and make sure there's no flow in the needle tract. And then I'm going to pull the needle all the way out. So then I'm going to double check to make sure there's no movement in the needle tract. There's no blood coming out of the liver, which is what I see here. And so now so that's it for the hepatic vein. Now I'm going to turn to the portal vein and I'm going to measure that 3 times and then we'll be able to calculate the gradient. So I'm moving now to the left portal vein. I'm getting away from the varices. I'm going to do E-flow Doppler, pulse wave Doppler. So this confirms that's the portal vein, right, Tom?
That's it. Look, that looks more like our traditional vein.
Yep. And there's my target right here. And Amber's gonna just hold my scope steady. And I'm gonna put my needle forward. And I'm gonna get my target there and go. And then I'm gonna come back and land my needle right into the portal vein, which is right there. Okay, so go ahead, mark and flush.
flushing,
Nice.
90,
90,
80,
80,
67,
67,
50,
50,
40,
40,
32,
32,
28,
28,
26,
26,
25.
25,
We're holding at 25,
25.
still 25.
Okay, 25. Let's record 25. Let's flush again.
Flushing,
Good. Excellent.
80,
80,
70,
70,
50,
50,
40,
40,
30,
30,
28,
28,
26,
26,
25,
25,
holding at 25,
25.
still 25.
Okay, 25. Let's record 25 as a second number. Let's flush.
Flush,
Excellent.
70,
70,
50,
50,
40,
40,
30,
30,
28,
28,
26,
26,
25,
25,
holding at 25.
25. So what were the 3 numbers?
25, 25, 25.
Okay, so very precise, Tom. 25, 25. And even I can figure the average of that. So what's the gradient? What's the difference between the 2 averages?
6.7.
6.7. So she has portal hypertension. Interestingly, it's not crazy high. It's not 12 or higher. So but it's elevated. So she does have portal hypertension, but not enough to create those large, varices. So there may be another aspect to it. There may be both a intrahepatic contribution to portal hypertension, but there also may be an extrahepatic component. But anyway, she has portal hypertension based on the gradient. So now I'm going to come out. I'm going to turn on the E-flow and move back out of the vessel.
And Ken, when you were flushing the needle, what were you flushing it with?
It's either pure saline, or you can also use very dilute heparinized saline. It's 100 units per ml. It's kind of like your Heplock that you use for IVs.
And that's just so you don't get blood clotting in the needle.
That's correct. So I'm going to move away now. The needle is out. I managed not to pierce those little vessels. So we're good. There's no bleeding from the liver. There's no expansion of the liver capsule. So the patient has portal hypertension. And the last part of the endo-hepatology is to get liver biopsy because there is consideration or concern that the patient has seronegative autoimmune hepatitis, maybe on top of NASH. So we're going to sample both left lobe and right lobe of the liver. So we're going to set up for that. If you want to transition back to UCLA, this may be a good time.
Perfect. Yep, we'll definitely do that. Good job, Ken.
Thank you.
We'll ask him when he comes back. Okay, Dr. Kim, we see you here. Both of you.
All right, welcome back, guys. So we started the ERCP here. I think you guys can see that the pancreatogram that was already shot on the fluoro picture. You see a big dilated pancreatic duct. In the distal duct, area in the head, heterogeneous filling. Effects are consistent with stones. We're gonna dilate.
Echo, but we can hear you.
Okay. Work on that. Should be good. We're going to dilate this stricture so we can facilitate passage of the spy scope or the pancreatoscope into the PD. All right, go ahead and go up. This is a 4 millimeter balloon. I'm probably going to stick that. Yeah.
You're doing the balloon dilation to facilitate the spy scope passage?
Yes. Because there's a stricture at the very end, or this very distal PD, which I think will make it very difficult for us to pass the spy scope at the moment. This is a 4 millimeter balloon. I think on fluoro, I think can certainly tolerate maybe a 6 millimeter balloon as well. So I'm going to serially dilate this up to 6, and then pass the spy scope through and see if we can find any of these stones in the pancreatic duct. Balloon down. Certainly, we can't always do pancreatoscopy. In this case, the PD is nice and dilated. The spy scope's a 10.5 French size diameter. So you have to have a duct that can fit the spy scope in order to perform this procedure.
And you had done a pancreatic sphincterotomy at one of the previous times, I would imagine.
Yes. When we shot our initial pancreatogram, there was some white calcified debris that was coming out of the PD. See if I can get some of that to come out now. If not, we'll certainly do a sweep later on, get more of this debris out of there. But I think pancreatoscopy is, just like cholangioscopy, a great tool when it's applicable. We've certainly used this in the past to differentiate chronic pancreatitis from a main duct ITMN. With chronic pancreatitis, you expect to see kind of smooth pancreatic duct mucosa, maybe dilated, but it should be benign appearing. With the main duct ITMN, you get kind of the fronds, the early changes of dysplasia within the duct. So now we're dilating to 6 millimeters. Go ahead. Here, balloon going up. A little bit of a waist there. Great. You going for a minute? No. Put the spy scope ready.
Yeah, so why don't we go through one room in the camera real quick. So while he's dilating up, I'm just going to show briefly kind of the way that we set up the spyglass scope. So we have it here. You should be able to see it here. And as you know, we're going to be irrigating with saline. So I've got one hook up there. We use saline so that way you don't get kind of hypoosmolar injury to the epithelium in the biliary tree. We'll give prophylactic, if we were in the biliary tree, I think we'd give prophylactic antibiotics. Are you going to give it here just to go into the pancreas duct?
I wasn't planning on it.
Probably not, I think. The other kind of trick that we have is we have a suction port on the spyglass here, and we actually, if you can see here, we've got a little 5 cc syringe, and what we do is we pop out the plunger all the way. So I've just got the syringe now. Discard the plunger, hook this up to the suction port, and then behind me we have a second suction. So one of the suctions is on our ERCP scope, and the second suction is here. And fortunately, we found that our tubing fits perfectly inside a 5 cc syringe. So I just hub it there, and now we've got a quick suction setup instead of having to find adapters, etc. So usually at this point is when we're really leaning over to our anesthesia colleagues saying, hey, can I borrow a 5 cc syringe? And so this is pretty much us ready to go. I like putting the spy scope down in kind of long wire fashion. So kind of gently pull it out, and I usually just hand it to my tech and say, just put this down like a long wire catheter, and then we'll hook it up to the scope. That way it just keeps it from twisting around. So at this point, I'll hand it over to Craig here, and he'll get it down over the wire to Dr. Kim, and then when it's there, when it's not kind of all tangled up, they'll hook it up kind of in a neutral fashion to the handle. So we can go back to a 2-room view at this point.
That's a nice trick for the suction. I like that. It's you want to be doing the suction just so you don't get too much pressure inside whatever duct you're in.
Yeah, exactly. It's kind of just sometimes you just need something to decompress it, and we try to minimize the amount of saline we're putting in anyway. You don't want to get, if we're in the bile duct, for example, translocation, overpressurizing the system, and the suction's a nice way to get that out. But in general, we actually have started reducing the water flow, the saline flow, I should say, just to kind of to avoid over-instilling anything. And so here we see Dr. Kim kind of going down. I'll switch over to the camera view here. Let's see what it looks like in there.
Are you turning the light down, please?
Put a what in the back of the wire? One room on the 50. Actually, Winnie? I think maybe what? Go back to the 2 room.
All right, there you go. All right, so we're getting this pancreatic scope up to PD here. Water's on?
Yeah.
All right, so now we got this nice view, the PD. Yeah, let's turn it up. And then just switch back and forth. All right, let's try to get some better visualization here in the PD. Yeah. Okay, and here we go. Here's the pancreatic duct where it's pretty dilated. If you can fit a spyglass in there, we know it's dilated. Up here in the neck.
If that's
biggest problem
good
is-
imaging, we can see it well.
Great. Just a little bit of bleeding from the dilation, which is expected, of course.
Yeah, this is obviously chronic pancreatitis. I don't think there's any doubt there. But let's say you were kind of, sometimes we get asked in these dilated ducts where you're worried about being a main duct IPMN, and they say, okay, let's go look for maybe some evidence of dysplasia. What might you see if you're looking for anything like that?
Yeah. Certainly in the cases where I've seen it, there's been these almost like polypoid growth within the pancreatic duct. These villus frons, friable, sometimes deep tumor vessels. A lot of the same things that I think you would see, in an early dysplasia in the bile duct, but certainly not this pearly white pancreatic duct mucosa you're seeing here. This is all just some blood from the dilation. So far, I haven't seen any stones. And again, we did get some stones out initially when we shot the pancreatogram with the balloon tip catheter. Let's see where we're at on fluoro. So we're almost coming out. Here's a stricture potentially here at the very end. It's a little hard to get the spy scope up because of the stricture down at the bottom here. But
So I guess if there's no stones, then you're really saying that his symptoms are more from ductal hypertension from the stricture itself then, right?
yeah, I think so. I think the stones are probably maybe somewhat of a byproduct of the stricture, but I think what we'll most benefit from potentially here is some stent, and hopefully we'll have the same response he had a few years ago when we did this.
And there is some data out there in terms of comparing surgical management, be it a Pisteau or a distal pancreatectomy, if it's pancreatic ductal hypertension and plus or minus stones causing pain in a dilated pancreatic duct versus endoscopic therapy. Any thoughts on that, and any, especially in relation to this patient?
Sorry. Oh, there.
Yeah. Oh, something there, maybe. Yeah, a little tiny boy there. Yeah, we sometimes, if we're losing the battle here, this patient's been through a lot over the years, but one of the nice things, we have a pancreas center with an integrated practice unit clinic every week, and basically you have the whole team at the table. It's almost like a tumor board, but it's not just for pancreas cancer. We kind of can discuss any pancreas case. You've got the surgical oncologist there, pancreas surgeons, interventional GI, oncology, radiology reviews the images, and it's one of those nice things to kind of discuss at a multidisciplinary conference. And there have been patients that they decide, you know what, it's time to go Pisteau. I think for this patient, it sounds like he does well for decent periods of time. And then I also, I think it's probably, what do you think, Steve? Probably dilated enough that they could do a Pisteau off this, a lateral pancreatic odrogeostomy. But, we'll present it if we think that we're losing the battle, present it at a multidisciplinary conference. And the nice thing about being at the center like this one, and like yourself, Dr. Speedy, you don't have to make these decisions alone. I love that part. We can ask for help when needed. But I think the thinking here is that we still have some options for him. He's been stent-free for a while. And I'm not sure that he's the best surgical candidate at this moment. And so we'll probably, I think it looks like, wow, Dr. Kim, so we can see on the x-ray here, you're pretty far up, and you almost drove it up to the tail, it looks like.
Yeah, so getting some great views. You can see even these dilated side branches. I mean, this side branch looks the same size as the main pancreatic duct.
And these are impressive views. Yeah, you don't see dilated side branches like that very often. This is amazing.
I think I see a small PD stone right here at 6 o'clock. See this calcification right here. So I'm going to attempt to get the SPY basket to try to get this thing out. This is the only kind of debris / stone that I've seen on the SPY glass so far.
Yeah, I don't think you're going to see a side branch dilated like this unless you have chronic pancreatitis, right?
That's right.
Pretty. It's almost like you're at like the biliary bifurcation here. It's like big ducts.
We may be going 10 pretty soon, but question, would you put once you get this stone out, it'll be good to see if you can, once you get the SPY basket through, would you leave a stent in, do you think, just if you're considering ductal hypertension as a cause of the pain, or would you see how he does just after the stone removal?
Absolutely. My plan was to put in 2 5 French single pigtail stents, keep the stricture open, see how he does, with hope that if he gets symptomatically better, then I think we have our answer as the cause of pain. Then bring him back, set the stricture, and decide if he needs any more stenting at that point.
Kind of give him a stent-free trial. So you're kind of saying you'll treat both things, get rid of the stone, but also the ductal hypertension, okay. and then buy some time, and then come back and maybe see if the stricture is better, and then try a stent-free trial again at that point.
Okay. Get close.
So beautiful imaging here. We have the SPY basket. So,
all right.
Nice. Great.
So we got this calcification in the basket here. You guys see that?
Yeah, that's a great use of the basket.
So I'm going to take the SPY out now. We'll drop it in a small valve.
All right, good job. That was fantastic. You're getting a lot of applause for that one. That was good. Maybe we should, Tom, if we. Yeah, there it is.
Yeah, good job.
Get out of there. All right. If they can want to do something else, it's fine. Otherwise, I'm going to put a wire for the stent. So.
Yeah, so at this point, I think you're going to go back up, clear the duct with the spyglass, and then plan is to get these stents going in there?
Yep.
Yeah, so I think we're just going to keep going here to wrap up this case. So we have the option of, if you want to just stay with us for a few more minutes, we'll just quickly put these stents in. We're going to clear the duct, and then we can just hand it off back to you.
Yeah. Let's see how Ken is doing. If Ken is ready for his liver biopsy, we can do that, or we can stay here as long as we want.
All right, well, I'm going to get the wire back up. I'll shoot a pancreatogram, and then plan on putting these stents up. If Ken is ready, you can cut away. If not, I'm happy to keep showing our stent placement here. I'd say one other tip about putting these PD stents in. I'm planning on putting in 2 stents. I want them to be 2 different size lengths. I don't want them to land in the same spot just in case it causes stricturing in the pancreatic duct. God forbid he doesn't show up in a month or 2 for follow-up. I don't want the stents causing more problems.
And why do you pick pigtail stents?
Yeah, I'm using a single pigtail stent with the internal flange. I don't want the stents to migrate in. That's what the pigtail's for on the outside. I don't want the stents to migrate out in this case. I want the stents to keep the stricture open. So I want to keep the internal flange as well. And in pancreatic duct stent placement for post-ERCP, to prevent post-ERCP pancreatitis, I often cut the flange or use stents without a flange so they fall out on their own. Is there a wire up?
Give us 5 minutes, right?
Yeah.
5.
We're going to switch over to UC Irvine just for a second, then we may come back and join you in a moment.
Okay, great.
Great, thanks. Hi, Ken. We can see you again.
Hey, Tom. Yeah, so I'm ready to do the first biopsy, which is left lobe, and then if time permits, I'll show you right lobe. So we're in the left lobe here, and right now I've got my 19 gauge Francine needle, and you can see here my needle tip. And I'm trying to do 2 things. I'm trying to find an area that is minimally vascular for me to throw the needle. And I'm also trying hard not to hit a varix up here. So as you can see, if I turn on the E-flow, we've got lots of vessels right there. And so I'm going to compress them and get them a little bit out of the way. And then down here, there's a vessel I don't want to hit. And then if I rotate this way, there's a vessel I don't want to hit. So this is a relatively vessel-free area, top and bottom, I think. Yeah. And then the final thing I want to do is I want to see how much liver I've got in front of me. So I've got about 7 centimeters of liver in front of me. So what I'm going to be doing is setting my needle guide at about 6.5 centimeters. And now I'm going to have Amber step over to my left. And I'm going to get myself ready because this is a single pass. I'm going to do 3 actuations because of our cirrhosis. So I don't want to go there. I don't want to go there. Okay.
Let's see, Ken, can you hear us? It looks like you may have frozen. See, Ken, if you hear us, let's. So Tom, if he's frozen, if we need to, we could switch or restart on his because we have nothing going for Dr. Chang right now, unfortunately. Okay, we're going to switch back over to UCLA for. Okay, so yeah, so we're back with you at UCLA and with Dr. Thacker and Dr. Kim? All right.
Okay, it looks like while Dr. Chang is preparing, so you could see on the screen here kind of our pancreatogram. Dr. Kim will show the hard state version in a second, but Dr. Kim's placing the first of his pigtail stents. We'll scroll back. It looks like you're past the marker there.
Right there, right?
Yeah, I think. All right, there's the marker. So the pigtail
Can you tell
stent.
us what French and what length stent?
5'7".
He's using a 5 French, 7 centimeter stent as his first one. So well across the stricture, so go ahead and see. So we can hard save that. Looks like you're in your scope. The fun of the really tiny pigtail stents. Okay, great, hard save that. And maybe Dr. Muthusamy back there with the mouse can just show the end of the stent with the mouse. And then Dr. Kim's going to recannulate next to it, and what size stent are you going to put next?
I'm going to go to 5'8".
He's going to go a little bit longer with a 5 French, 8 centimeter stent. And so as he does that, while he does the exchange, Dr. Muthusamy, maybe you could scroll back a couple of images, and we'll just show some of the hard flora of the kind of the final pancreatogram. So that one and the one maybe before that as well. So you could see the difference now after the dilation in the distal duct. Contrast was kind of flowing nicely compared to the initial, where you really didn't see much filling there at all. You just had the dilated duct. So the dilation, maybe getting that stone out, will hopefully take care of the trick, and then the stent will just be in here as a little bit of a safety net. So we'll be wrapping it up here, I think, in the next few minutes, but we'll hand it off back to Dr. Chang as we place this last stent. It's going to be a 5 French, 8 centimeter, a little bit different length, a little longer, and then we'll see how this patient does.
Okay, that sounds good. Thanks. I think we could switch over to Ken Chang at Irvine. I think if we, oh, good, Ken, we can see you again.
Yeah, what a great timing for dropping the call, huh? Okay.
You were so
Okay.
quick, we thought you were on the next case now.
All right, so I've got my needle. This is the sheath poised and ready. I'm trying to avoid that vessel, and I've got a reasonably clear field in front of me. So I'm going to get everything ready. I don't want to hit that vessel. I don't want to hit that vessel. I'm going to go right here. All right, so now I'm going to have Amber go ahead and take everything off. Okay, I'm going to go real fast now. And boom, okay. And go ahead and put this syringe on.
Do we always have to say boom?
Yeah, I do.
Okay, good.
Okay. So then I turn the suction on, and then I turn the suction off. And that's merely to bring the specimen that I've cut through the needle. So now I'm going to bring the needle back. And there's my needle coming back. There's a little bit of a shadow there. So I'm going to stop right here, and I'm going to change my angle a little bit. So I'm going to change my angle by bringing my big knob away. I'm still in good position. And now I'm going to reset my safety. I can go a little bit longer this time. Okay, Amber, if you could turn suction on. Boom, suction off, okay. And then we're going to do one more. So it's three actuations. So I'm bringing the needle back.
So Ken, you're not really moving it back and forth within that track, are you? You just kind of like doing it a slow pull back, okay.
Yep. So I'm going to bring it back to about here. Okay. And let's have you suction on. Go, suction off. Okay, so that's 3 actuations. And that should pretty much load up my needle with a bunch of specimen. So what I'm going to do now is I'm going to back out. And I'm going to back out to the common channel where the 3 passes or 3 actuations were done, which is right about here. And here I'm going to zoom in a little bit, mag up a little bit. So this is my needle tip. And now I'm going to turn on the eFlow and take a look if there's any flow. So I'm looking for flow here. And so far I'm not seeing any flow in my needle track. So I'm going to back the needle a little bit. And I'm going to look for flow here in the needle track. I'm going to back it up a little bit more. There's no flow there. There's no flow there. I'm going to back it up a little bit more because there was a little bit of flow here. So I'm going to slow down a little bit. As long as I don't take the needle out, the blood just moves in the needle track and eventually it stops and it gets reabsorbed. So right now I'm just holding still here. So you can see there's some flow here. There's flow from the varices up here. This is my needle tip. And I don't see anything flowing towards my needle tip. So if I do see persistent flow in my needle track, then the best thing to do is wait and let things just clot with time up to 3 minutes. But then if it persists, we just recently reported in Video GIE a technique called EOS blood patch delivery, where we simply put the stylet back in the needle and redeliver 25% of the last portion in the tip of the needle back into the needle track. And then that's clotted blood, most of it, and that will help to tamponade the needle track. So it's nature's gel foam, we call it.
Oh, good idea.
Yeah. Okay, so I think I'm going to move back slowly here. Hopefully I didn't spear a varix. So far, so good. I think I was able to just miss them. I'm okay there. Okay, so now I'm at the, gastric wall there. I'm right at the muscularis propria. And now I am out. And now I'm going to bring the sheath back out.
Good job. And so will you go and do the other lobe now? Do you do both lobes for every patient?
Pretty much. The yield is tremendous. And then it takes care of any issues of the sampling error. So I want to show you a little bit of the tissue handling and take a look at the gross specimen. So over to my left, I've got a little counter with a second camera, and we can show you that.
Great. And then I think we might end up doing, after we see the specimen, Ken, we may see Jason's video, maybe what we'll do next.
Perfect. All right. So I don't know if you see me in camera 2 here.
We see well.
Okay, perfect. Let's have needle out. Okay, we're going to aim right here, and Amber's going to go ahead and flush.
And can some people put this on filter paper or some sort of paper? Do you do that?
Yeah, I do that. Stop. Okay. Yeah, I spoil our pathologists severely. So I've got this little well here, and in that well is a lot of liver core, and I'm going to go ahead and fish them out so you can see the crazy length that we can get. So let me take them out here. So there's an insane amount of liver here, Tom.
Yeah, and you can see when you separate out the blood clot part from the white kind of tissue there. Yep. And Ken, we have a question at the mic while you're doing that.
Hello. Gene M. I'm a hepatologist from Mount Sinai, New York.
Hi.
Hi, Dr. Chang. So I'm gonna play devil's advocate a little bit. So while I appreciate these new applications of technology, I think the biggest question is whether or not you could gain the answers to some of the clinical questions that your fellow posed without doing these kinds of portal pressure measurements in particular. Because I think, as a hepatologist, I probably would not refer a patient like this for, these kinds of more invasive measurements, unless there was something discrete that I was sending the patient for, like a surgical procedure, for example.
Yeah. I really appreciate your perspective. Let me first describe the specimen, and then maybe you can comment. Do you like my specimen at least?
I do like your specimen very much. Yes, I'd be very pleased with that.
Okay, so we'll start off on a good note. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15 centimeters of liver. And we're going to put them onto the filter paper. But I promise I'll address what you said. But I'm getting old. I can't multitask. Okay. So
how does this compare to the liver biopsies that the hepatologists get when you do your bedside ones?
Yeah, I mean, I think it depends on the practitioner. I think Dr. Chang is showing that he's an expert in this. They are a little bit thinner in caliber. A lot of it has to do with, whether there are complete portal tracks, there, and fragmentation. So the fact that you're not getting a lot of fragmentation in a cirrhotic patient is quite impressive. It's almost like a hepatectomy you did.
Okay, Ken, you can change this to endoscopic hepatectomy, okay?
all right, you like that?
Yep, that
Okay.
works good.
Okay,
Reach on
so Mark, can you finish putting that to bed? And then I want to address. Yeah, thank you. Okay, so let me answer that. So in this particular case, one can certainly argue, did we really need to get a portal pressure measurement? Because the patient has gastric varices. The patient has perisplenic varices. So almost by definition, the patient has portal hypertension. So if the answer is dichotomous, is it yes or no? Portal pressure, yes. Portal pressure, hypertension, no. We didn't need this. Absolutely agree. But if the question is, well, how high is the gradient? Because those varices have never bled. So would you do intervention? Would you start a non-selective beta blocker? Some hepatologists will say, well, I wouldn't because the patient never bled. Other hepatologists say, well, emerging data suggests that if your gradient is very high, starting a beta blocker makes sense. So there is some variability in terms of how a hepatologist would manage. So I did talk to our hepatologist before the case. I said, look, if I see varices, do you want me to measure the pressure or not? And if it doesn't make a difference, I will not. And he said, no, please, I want to know what the pressure is. So again, it's not for us to say when it's indicated. It's really for you all, hepatologists, to tell us when is this helpful. This is a collaborative thing. It is a new area, and I fully appreciate and understand. We don't want to be cowboys doing things that just because we can do it, we're doing it. Absolutely. That is not what we want to do. That would be absolutely wrong. But it is a new technology that has some differences from the transjugular approach. less invasive, more available. You can do it in combination, and it's a direct measurement. And for example, the whole NASH field and NASH cirrhosis is still emerging, where HVPG may be underestimating the true portal vein pressure, because NASH may be a combination of sinusoidal and pre-sinusoidal hypertension. So this whole field is kind of still evolving, and we've got a technology now that can be looked at, investigated. So I think in that rubric, it's, for me, you know, how do we leverage this technology to help the patient? That's really the bottom line. But I really appreciate what you said. For this patient, another hepatologist would have said, why did you do that? I didn't need that. That's not going to change my management. And I fully understand that.
Okay, well, we're gonna, thanks. No, great question. And we're gonna, Simon Lowe from Cedars is joining us now. Thanks, Simon. And he has a question for you, Ken.
Well,
hi,
I don't
Simon.
have a question. I just want to, hi, how are you? I just want to make a comment that those long strip that you pull the tissue out was so beautiful. And we try many times, we fumble over that. So just want to let you know that it's beautiful, not just endoscopic technique, but also the pulling of the tissue. We usually just call them up and we just gave up.
No, excellent case, Ken. Fantastic.
Thank you.
We're going to put Jason's video on hold for perhaps later. We're going to take a break now for 15 minutes, then we're going to come back and resume the lecture. So Ken, strong work. Good job.
Okay,
Thanks.
we'll see you tonight, maybe at dinner.